Good day, and thank you for the opportunity to provide a Canadian perspective on health sector reform. I'm sorry that I cannot appear live today. I am currently the Vice President of Health Policy and Research at the Canadian Medical Association, where I've worked for 23 years. The CMA is a national professional association representing a majority of the physicians in Canada, and we advocate on behalf of physicians and patients. ACRM asked me to address several topics, but I would first begin with ethical theories underpinning health systems, because I think that is fundamental. Certainly that has been the case in Canada. Just a quick note about our health system. Canada is a federation of 10 provinces and 3 northern territories. Our population is some 35 million. Our Constitution of 1867 effectively granted responsibility for health care to the provinces. The federal government has jurisdiction for the health care of Aboriginal peoples, the military, and inmates of federal correctional institutions. However, since the 1950s, the federal government has provided financial transfers to the provinces and territories for health care. Our national health care program began in the 1950s, first with hospital insurance and followed by coverage of medical care in the 1960s. I believe that this was the result of a consensus around some core principles that we generally consider to be values. The original ones were universality, all residents had to be covered; portability, people would be covered wherever they moved in the country; comprehensiveness, all insured services would be covered; and lastly, public administration. While delivery might be privately provided, the administration would be public. In 1984, a fifth principle was added, accessibility. This means that there can be no financial barriers to accessing hospital and medical services, such as user fees. These principles are set out in the Canada Health Act, and federal transfers to the provinces and territories are contingent on them being satisfied. What this practically means is that virtually all of physician and hospital expenditures are publicly financed. However, an open question remains: is this the extent of the consensus? The issue here is that healthcare is now much more than doctors and hospitals. Prescription drugs are now the third largest item of healthcare expenditure at 13%, behind hospitals at 28% and physicians at 15%. I think our experience is important for anyone designing a health system. While incrementalism may be practical in terms of financial affordability, you also need to be able to entertain future expansion. Thus far, this has eluded us in Canada. Less than half of our prescription drug expenditures are publicly funded, and many Canadians have difficulty in affording their medications. Looking ahead, we will face the challenge of providing both home-based and institutional care for our aging population. The degree to which this will be funded on an individual versus a pooled risk basis is very much in question. So the lesson is you need to think about how values and ethics shape health systems. Let me turn to health sector reform. I think it's fair to say that the largest experimentation with health sector reform in Canada in recent decades has been in the area of decentralization. Since the 1990s, virtually all of our provinces and territories have gone through at least one wave of decentralization. Many have gone through 2 or more, and now we are starting to re-centralize. The most dramatic example is the province of Alberta, which started by reducing some 250 health boards down to 17 regions in 1994, then consolidated further to 9, and now to a single region. It is not clear, however, what decentralization has accomplished, and I think that one reason is that jurisdictions were not clear on their objectives. In effect, decentralization has consolidated governance of the range of institutional and community-based services. But you have to wonder, if you want to have a system grounded in primary care, what kind of challenge does that represent? Also, in the Canadian experience, I don't think we've been that successful in shifting from institutional to community-based care. Another issue is that governments continue to intervene. Health remains a political issue and will probably always be so. So I think a key lesson is to have clear objectives and a means of measuring progress against them. Next, on the theme of market incentives, I would like to highlight one reform that we have not tried in Canada, but which has been adopted extensively in European systems, which is the internal market. And this is a means of stimulating competition within a publicly funded system. The United Kingdom pioneered this in the early 1990s, inspired by the work of Alain Enthoven. One of the challenges in Canada is that we have not only only 3 really large population centers that would support competition. However, more recently, Canada has been one of the last industrialized countries to move in the direction of activity-based funding for hospitals along the lines of prospective reimbursement linked to diagnosis-related groups that were adopted in the United States in the 1980s. In effect, activity-based funding means that hospitals are competing on the basis of quality and efficiency and not on price. Another issue that we have been reluctant to pursue in Canada is the issue of choice and rights. Referring back to the fundamental principles of our system, they only assure that all individuals receive care on uniform terms and conditions. There is no assurance that they will receive timely care. As a result, we continue to have long waiting times for specialist consultations and elective surgical procedures. Our federal government introduced a wait time reduction fund in 2004 to address 5 procedures such as hip and knee replacements, and there have been some improvements. But overall, this has not been the rising tide that lifts all boats, although it has resulted in a growth of operations research and measurement in the health sector. Our province of Alberta has recently introduced a health charter for consultation, and I hope it will be adopted, as it could provide an example for other jurisdictions to follow. So I think another lesson from our experience is that if you want to sustain a universal system based on need, you have to be able to access the care that people need in a timely manner. Next, I would like to comment on public-private partnerships, or P3s as they're called. First, I would note that while 70% of the health care in Canada is publicly funded, the majority of care is privately delivered. Physicians, for the most part, are independent contractors. Where we have used so-called P3s is mainly in the capital funding of new hospitals and other healthcare facilities. In my view, the jury is out on how cost-effectiveness these are in terms of value for money for the public purse. Looking ahead, however, as we can deliver more complex surgical procedures outside hospitals, we will probably see more private facilities that will provide publicly funded services. I would add that most of our provinces have some means of regulating the quality of care in private facilities. I would conclude my comments by emphasizing the need for a quality framework in a healthcare system. I think the United States Institute of Medicine has captured it best in their 2001 report, Crossing the Quality Chasm. The IOM report lists out 6 dimensions of quality: safe, effective, patient-centered, timely, efficient, and equitable. We've been embracing these elements slowly in Canada. One of the problems has been that there has been a preoccupation with timely access over the past decade. We have also put a lot of emphasis on patient safety, but we have a lot more work to do on these and the other dimensions. I would add that, in my view, it would help to have a national quality framework that would support the development of comparable indicators. We now have 7 different provincial health quality councils in Canada, and there is variation in the elements they include and the things that they measure. In closing, let me thank you again for this opportunity of addressing your conference. I wish you all the best in the reforms that you're planning and carrying out in Iran. Thank you very much.